Good afternoon.
He does now.
Good afternoon, and thank you for coming out on such a splendid Maryland April afternoon. And I welcome you to the first annual Lipitz Lecture, to be delivered this year by Professor Carlo DiClemente of the Department of Psychology, who is the first Lipitz Lecture, Lipitz Professor of Arts, Humanities, and Social Sciences. The Lipitz Professorship is supported by an endowment from Roger Lipitz and the Lipitz Family Foundation. And the endowment was provided in order, and I quote, to recognize and support innovative and distinguished research in the arts, humanities, and social sciences at UMBC. It's awarded annually with a one-year tenure. And it's the first such professorship to honor and support distinguished faculty in the College of Arts, Humanities, and Social Sciences, which has more than its fair share of highly productive and distinguished faculty. I am therefore delighted that the Lipitz Foundation has provided us with this opportunity. As I'll say in a few minutes, it's altogether fitting that Professor DiClemente was chosen as the first Lipitz professor. Before then, however, it's my great pleasure to publicly announce the Lipitz Professor of Arts, Humanities, and Social Sciences for academic year 2008-2009, and that will be Professor John Sturgeon of the Department of Visual Arts. Professor Sturgeon is an internationally renowned and pioneering artist in video and new media, whose work, fittingly enough, also embraces other disciplines in the humanities and social sciences. He is the winner of fellowships from the Guggenheim Foundation, the National Endowment for Arts, and the Fulbright Foundation. His works are in collections in important museums and other institutions around the world, including the famed Museum of Modern Art in New York. He is one of a small handful of pioneers in video art, whose work will be archived in the J. Paul Getty Museum and Research Center, arguably the most important art institution in the world. And Professor Sturgeon will use the Lipitz Professorship and the funds associated with it to restore some of his earlier works for transfer to the Getty, and then also to work on two new projects that he has. And a wonderfully distinguished professor in the college, and I, with all of us, look forward to his lecture this time next year. It is now my pleasure to introduce the first Lipitz Professor of Arts, Humanities, and Social Sciences, Professor Carlo DiClemente, another world-renowned scholar, in this case of addictive behavior. And he's been not only a prolific scholar, but also a consultant to a variety of organizations. His work is distinguished not only by its scholarly rigor and the contributions it's made to scholarship, but also to its important practical applications. He's author of more than 100 publications and peer-reviewed in other outlets. He has won millions of dollars of funded research. He has awards and distinctions, national and international, too numerous to mention, but they include being a fellow of the American Psychological Association and recently the John McGovern Award from the Society of Addiction Medicine. In addition to his remarkable and important scholarship, he has also been a really significant figure in the life of the university since his arrival here in the mid-1990s, not only as a longtime chair of the Department of Psychology, but also in any number of other ways that have enriched UMBC's life and helped to build UMBC as an institution. He's brought distinction to himself, to his discipline, to his department, to this college, and to the university. It's therefore my honor and pleasure to introduce Professor DiClemente, who will speak today on making a difference, evaluating the complicated process of behavior change. And I should note there will be a question and answer period to follow, and then a reception. Professor DiClemente.
Wow, and I thought you couldn't get that kind of an introduction in your own home institution. So this is wonderful. Thank you, John. I appreciate that. I'm very pleased to be here today and to actually tell you about some projects that we're working on, and especially the project which is really not research as much as it is dissemination of our work into the community. And so we'll be looking at kind of how you can evaluate kind of making a difference, and from the perspective that I use. What we have done over the past 3 or 4 years is create a Center for Community Collaboration here at UMBC in the Psychology Department. That center is really dedicated to looking for opportunities to build academic and community partnerships in Maryland that would both help kind of the students in terms of creating some engaged scholarship as well as community empowerment. The stimulus for that particular center, even though I work in addictions and mental health areas, actually came from the AIDS administration. And we have funding from the AIDS administration, from the Department of Health and Mental Hygiene and the Office of Tobacco Control. And we've had some funding from some community agencies. The Lipitz professorship has actually funded the project that I'll talk to you about today. And hopefully there'll be some grants. We actually have something into the CDC and others to fund additional projects. We have a departmental advisory board, and some of those department advisory members are here, and I appreciate that. This center really has two kind of components to it. We really have the HIV/AIDS capacity building project, and I'm going to talk about the projects, but actually these are all the people who are involved in doing them. So you can look at that. These are the individuals, doctoral level and our graduate students, who really have helped build this project and make it successful. The AIDS capacity building is what we're going to be talking about today. We also have the MD Quit Resource Center for Tobacco Use Prevention and Cessation in the state of Maryland, funded by the Department of Health and Mental Hygiene. And we do a lot of work around the state in working on trying to help people to change and to prevent tobacco use and to change behaviors of those who already have that. We're not going to talk about the Center for Tobacco Use today. We're going to focus on the AIDS projects, because those are projects that I have a harder time finding funding for. So the Lipitz professorship actually was very helpful in kind of getting us some money to do that. The center is a partnership with the AIDS administration to provide some capacity building, or especially around substance abuse, mental health, and medication treatment adherence in community agencies. And so basically what we've done is we've provided assessment and training and services to over 10 agencies funded by the AIDS administration. And these agencies include, Healthcare for the Homeless and Project Place and STAR and League with People with Disabilities, all of whom have funding to reach out to people who are HIV positive. So all of this is Ryan White funding, and this funding comes and must be used for individuals who are HIV positive. Let me tell you just a little bit about HIV in Maryland. As you can see, the largest, the dark red, if you can see that, is actually Baltimore, and the number of cases in Maryland, in Baltimore in 2004 was about 14,500 just in the Baltimore area. And AIDS actually, as you see, kind of has pockets of cases around Washington, around Baltimore and Baltimore County, and then as you move out, it gets to be less and less. The light blue is only 1 to 100 cases during that time in this area. So you see that its distribution of HIV cases is really kind of skewed. There's also a tremendous skew in terms of where HIV is found in terms of populations. This is the ethnic and racial composition of Maryland in 2005. It's about 60% white, 30% African American, 6% Hispanic, and 4% other. This is the distribution of new cases of HIV in Maryland in 2006. 79% African American, and only 16% white, 2% Hispanic, and 3% other. What you see also in terms of new cases of AIDS in Maryland in 2006 is that 83% of the new cases of HIV/AIDS, HIV turning into AIDS, transitioning into AIDS, were in the African American population. So HIV in Maryland is an unequal opportunity disease. Maryland ranks about 9th among states in the prevalence of AIDS cases, with African Americans accounting for 75% of the cases. Progression for risk from HIV to AIDS is 80% in African Americans and only 10% in the Caucasians. AIDS actually was the leading cause of death among African American men and women in the age group 25 to 44 in 2003. It's also true that HIV and AIDS doesn't come simply by itself. Rates of psychiatric disorders are greatly elevated. Upwards of one study had about 53% of women who have HIV/AIDS actually with depression and other psychiatric illnesses. And injection drug use, actually in Maryland, is a greater risk than across the country. It's a more common mode of transmission in Maryland, about 41% of the transmissions versus about 18% nationally. So what you see is a disease that actually is population specific in some ways, is area specific. It's all over, but the pockets of where it is and who it affects is very specific to Baltimore and the surrounding areas. What's interesting is individuals with HIV/AIDS, no matter what the source of transmission, face a variety of medical, social, economic, emotional, and psychological kinds of problems and risks. The good news is that medicine has been able actually to allow individuals with HIV to live much longer. However, the challenges then for the individuals and the society become greater with the increasing longevity. HIV status is typically only part of a picture that's filled with lots of other problems: poverty, homelessness, stigma, trauma, social isolation, issues of racial, social, and sexual identity, and health and mental health problems. So it's a complicated, when you're working with individuals with that, it's very complicated. So the project that I chose and asked for the Lipitz funding for was really a project that we began working on, but had no funding for, to work with the AIDS Interfaith Residential Services program in Baltimore. It's a housing program, and we'll go into that. And they're connected with Empire Homes of Maryland that actually does the leasing of the houses for these individuals. So the mission statement was to provide residential services and a continuum of quality care and support that enhance the lives of low-income individuals and families living with or at risk for HIV/AIDS. It was actually founded in the 80s by the Central Maryland Ecumenical Council as a way for faith-based communities to kind of actually reach out and serve these individuals. They operate about 171 units. They own about 22, and then they rent a number of units across mostly Baltimore County, where they have scattered site housing for individuals who are eligible for their services. They also try to provide case management. So they also try to provide an individual service plan for each resident that goes into the housing to actually support them, and that's where we're coming in. So the challenge that they brought to us was how to help the case managers evaluate and assess the needs, the readiness to change, the priorities and progress for a very diverse group of clients with multiple problems who are given housing in this program. So that was what they came and asked us to help them with in the center. Now this is a sample, this is a picture of kind of who are the people who come into this particular program. 70% are between the ages of 41 and 60, another 28%, so virtually 90% are between 25 and 60. This is a pretty problematic, obviously homeless population who are seeking housing. So 80% are unemployed, 82% on SSI or SSDI. And the main focus is their HIV status and the need for housing. That's the two things that you need to get into this particular program. But that's not all they bring into this program. They walk into the program with mental illness, substance abuse, illiteracy issues, legal issues. There's a sub-program that actually gets prisoners who are coming out, who are HIV positive, that they try to use housing for. Unemployment, life skills deficits, lack of family support, parenting difficulties, lack of motivation and adaptive coping mechanisms, obviously stigma, and for the African American HIV positive or AIDS folks, there's the double stigmatization that are actually there, or triple if you actually add in prisoners. So we have lots and lots of different kinds of problems that these people are facing. So there's lots of barriers in terms of problems, but there's also barriers in terms of a lack of trust and a sense that these individuals, from the case manager's perspective, give us the right answer because they want housing, obviously. They try to figure out what they should say in order to get in there. However, they have strengths. I mean, the strengths include survival skills. They have street and system smarts. I mean, they probably know the social system and how to get around better than most of us. The other kind of strength is that 60% of these individuals stay in housing for greater than 24 months. So they have access to these individuals over long periods of time and want to be able to help them. About 29% are in from 10 to 24 months. So again, about 90% of the people are there for more than 10 months. In which, if you're in social services, that's a long time to be able to have access to anybody in order to be able to provide some care. So why did they come to us for help? Well, actually, the psychologist who was on their board, who, when they started talking, they wanted to talk about readiness and motivation of these clients, and that many of these clients were unmotivated. And she said, well, why don't you go and, I know that Carlo does some work in motivation and readiness and around substance abuse. Why don't you go and talk to him and see if we could, you could get him to help you do this. So the reasons they came to us is that we really do focus in my research and in my lab on motivation and the process of intentional behavior change that I'll talk to you about in a few minutes. We focus on a process rather than just the problem or a product perspective. So you really think about how people change, not necessarily what they're changing. And so the model has been used across a number of different kind of behaviors. We've created a multidimensional model. Actually, my major professor and I developed this trans-theoretical model as I came out of grad school. And it specifies key dimensions of what we think about as the intentional change process. And we've talked about stages and processes and the context of change, and I'll give you more about that in a minute. We also have focused in lots in my career on assessment, because I think assessment and feedback are really important in order to be able to empower not only the case managers, but also individuals. So lots of the brief interventions that we do in terms of our research have feedback as part of that. So you do an assessment and you give feedback to people, hoping that the feedback will actually help in the motivation and help them move forward. So that's why I think they turn to us. Now, we'll kind of switch gears and kind of go into behavior change. Actually, if you really think about it, the reason that I think my work has been accepted and used around is that if you think about behavior change is really critical to growth and development of all kinds of operations, organizations, societies, and individuals. Because if you think about the organizations, every organization has to change in order to adapt. I mean, we have to do that at UMBC, other organizations have to do that. Every successful organization has got to adapt in order to meet the challenges that it's going to face. And the key questions for an organization or society are always what, whether, and how to change. And if you go on the individual side in the right-hand column here, it's the same thing. Individuals have got to change and adapt in order to be able to meet the changing demands of life. Okay? So we have to make changes in our life. Actually, failure to change on a kind of psychological basis is really seen as a sign of stagnation in pathology. Rigidity and failure to change is really part of that, what we see as pathology. And the key questions for the individual, as for the organization, is whether, how, and what to change. So there's similarities across those two areas. And the model that I'm going to tell you about has actually been used for organizations as well as for individuals. Now, what's the challenge? I mean, for all of you, all of us have to change, actually. So what's the challenge? Well, there's lots of challenges to change. None of us really, we've found a comfortable way with doing things the way we do them. So nobody really wants to change the way they do things. Change requires letting go of the familiar, kind of embracing a kind of an unknown of where you're going to go, so you have no clue of where that's going to be. It involves disruption, so you really don't want to disrupt your life. I mean, none of us like it even when there's a detour. We've got to go to a different route coming in. It's like, oh my God, that's terrible. And change requires vision and hope. You've got to be able to kind of think that if I'm going to change, it better be something good that I'm going to change to. Most of us don't try to change to something worse. That doesn't always work, but that's the goal anyway, is to try and change to something good. It's also interesting because in the work that I've been doing, change often is behavior specific. People will change one aspect of their behavior and not necessarily others. So even in drug abuse, we have individuals who will change their mode of using the drug rather than the drug itself. So people will say, well, I stopped shooting up heroin. So they've made changes, and they are very proud of themselves for having made that change. They're still using heroin, but they have stopped shooting up heroin. And people do that all the time. People go, with drinking, and people go, I don't think I really want to quit drinking. I just like to cut down or moderate on my drinking. So people make choices about the goals and how they can do that. It's also true that changing many things seems harder than changing one thing. This particular individual kind of gives you some sense of that. This is a middle-aged, we'll call him, individual visiting a doctor, and the doctor says the best way to achieve health and take care of yourself, your lifestyle is destroying you. You must change your eating habits, stop smoking and drinking, start an exercise program, get plenty of rest, and learn how to handle stress. None of us have been giving those particular recommendations. And the individual, as we mostly do, say, yes, thanks, you're right, doc, this is really wonderful, and then goes out thinking, I must change the doctor. Because it's always easier to kind of change the messenger than it is to follow the message. So how can we use this kind of change perspective in terms of these heirs clients? Well, what we try to do is actually kind of use both this process and a consumer perspective. I've been doing some work in tobacco control, and we've been bringing in, I don't know if any of you know IDEO and Tom Kelly. IDEO is a firm that does transformation and product design. And they have been helping us in the smoking area to try and rethink how we kind of market our products and services to smokers. And it's been really interesting. And they take a anybody use a toothbrush that has a big handle? Like a fat handle? Yeah, those are designed by IDEO. The laptop mouse was designed by IDEO. So they take a consumer perspective. They say, we have to first of all find out what the consumer needs and what they want to do, and then try to figure out how you can help them. And so we try to take a process at a consumer's perspective here in trying to kind of evaluate and look at this. If you think about the heirs clients, oops, I got too far ahead of myself. You have both the clients who you take the individual perspective, and you have to look at change. Change is, involves, it's not just an on and off switch. We're not just going to get them employed one day because they're unemployed. We're going to turn a switch and make them employed. It really consists of multiple challenges and multiple tasks, and I'll kind of focus on those in a minute. It requires multiple skills, it has cultural dimensions, and it involves the ability of the individual to self-regulate. And that's part of the challenge of change for all of us. But this change, if we're going to evaluate this in this system, also has system dimensions, because the individual change is going to happen in the context of the larger system. So the change is actually going to involve also multiple consumers and payers, because these individuals who come in off the street have multiple needs that get met by multiple people. So it involves consumers and payers that are providers, multiple providers, healthcare systems, families, communities, because it's housing. They live in communities because they're not living separate. Business, because they're trying to get them employed. That's one of the goals of the heirs group. And government. Much of the some of the funding from this group comes from HUD as part of the housing, and HUD wants them to get some employment. That's the goal of their particular program. So there are multiple agendas from both a system perspective as well as an individual perspective that are coming together to kind of think about this project. Now, why don't you people change? I mean, why don't you change? Well, I mean, most of the time, people, we can talk about organizations too, there's usually three dimensions that we're willing to talk about. They're not convinced of the need for change, and so they say we're unmotivated. They're not committed to making the change, so we say those people are unwilling. Or either they don't have or they perceive that they don't have the ability to change, and these people say they're unable. But think about that. Each of those dimensions are part of a process, and they're different aspects of a process. We talk a lot about motivation, and especially in drug abuse, they talk about us being not motivated, that drug abusers are just not motivated. That's really not true. Drug abusers are motivated. They're just not motivated to do what we want them to do. That's the same as your adolescent kids. They're motivated, they're just not motivated to do the homework and the stuff you want them to do. So we have the motivation that's there, but it's not really focused on what we want it to be focused on. It's not focused on the change. It's focused on doing the same thing that they've been doing. It's also true in psychology and a lot of our research. I mean, I followed people for years who were smokers. I followed people for years who had serious drinking problems. And many of them don't change. So people who seem to have everything to gain oftentimes don't make the changes that we think make sense. The other part that you learn clearly, and the graduate students here in psychology know, is that we have some really wonderfully effective self-management techniques for anxiety, for phobias, for other kinds of things, problems. Even people who come voluntarily to seek help don't follow through and do the procedures that are taught them in the sessions. So lack of change is really is kind of a conundrum that most of us have to kind of face, I think, in society, but also in psychology. And I think the solution to that is really the only solution to that is really trying to get the clients, in this case the heirs clients, to become partners and participants in the process. Because if they don't participate in the process, they won't succeed long term. I mean, we can make people change. I mean, when I give a talk to the substance abuse community, I said, I can stop people from using drugs. I have to throw them into a good jail. A jail where I know who the jailers are, where I have control of everything so that they don't sneak the stuff in, and I can make a drug abuser stop using drugs. I mean, what's the problem with that? You have to let them out. And when you let them out, they start up again right away. So change is, you can enforce change and impose change, but the process that I work with is what we call intentional change. So, how do people change? This is one where I got someone to help me with this stuff. I don't know how this works. Actually, this wasn't supposed to do this, actually. We'll see. Too technologically advanced for the speaker. If I want to get each of you to change something today, what do I have to get you to do? Well, I would first have to get you interested and concerned about the need for change. Then I would have to get you to become convinced that this change is going to be in your best interest, that it's going to benefit you more than it's going to cost you. Then I would have to help you organize a plan of action and make sure that you were committed to that plan of action. Okay? And then I would you'd have to take the actions that are necessary to make the change happen. Okay. So all of you, we're well past New Year's. So most of you had some New Year's resolutions, I'm sure. And you can just look back on those to see where you are now about the resolutions that you made in the past. And typically you'll find that somewhere along the line you didn't do one of these kinds of things if you're not continuing to do the New Year's resolution. If you are, you probably have had a sense that you've become interested, concerned, built a plan, got committed, and you're continuing to do what you were supposed to do or what you planned to do. The model that I work from that we've been researching for the past 25 years is this model here called the trans-theoretical model, because we've taken principles from a lot of different behavior change theories. And basically, what you have in this model is kind of a motivational dimension, if I can get this going here, that are called the stages of change. Think of these as like engines of change, that if I have to get you to kind of get involved in some of these processes in order to get you to move through these stages, and both of these are really revolving around a particular behavior that I want you to change. So the understanding is that that behavior change, whatever you're changing here, happens in the total life context of the individual. And so we have what we talk about as the context of change, and I'll talk a little more about that. There are also some markers of change. I'm not going to go into those. So the idea about motivation then is motivation is best understood as kind of the readiness to accomplish these tasks of these different stages. And there always are facilitating and hindering factors that are going to get in the way of you doing these tasks. And so if we understand the process, then we could better kind of deal with and intervene with that process. And it's also important to understand, and especially since you know the figures that I presented earlier about ethnicity and location and where people are, is that culture and ethnicity influence the accomplishment of these tasks and create either hindering or facilitating factors that help people to move through this process and to change. So what we've done with the stages of change is really kind of just segment the process. So all of you are in a process of change for whichever behavior that you have thought about. You're either here in pre-contemplation for that behavior, so no, I'm not doing any exercise program, or I'm not going to the gym, or you're, and what's the challenge if you're here is I have to get you interested and concerned. If you're thinking about it, you have to do a risk-reward analysis and make a decision. If you're preparing, you have to get the commitment going and create an effective and acceptable plan to make change happen. If you're here, I have to get you to implement the plan. If you're here, I get you to consolidate the plan. So I'm going to run through quickly these things, because it doesn't mean this person isn't interested at all in changing. We have a lot of people, if you do a survey of the smokers in the state of Maryland, there's not very many of them who will say yes to, are you seriously planning to quit in the next 30 days? There's another group of people who will say yes to, I'm seriously thinking about doing this in the next 6 months. Anybody who doesn't say that is really in pre-contemplation. If you're thinking about doing something 2 years down the road, it's really a little too far for planned behavior change. So we think about these people as being in pre-contemplation, and that they need to become aware, envision the possibility, and get concerned. So this is what we're going to try and help the AIRS folks to do, is identify where people are in this process and reach out to them with techniques and strategies that are more geared to this particular stage as opposed to other stages. In contemplation, your challenge is analyzing the pros and cons and coming to a decision. So the decision to change, though, has two key components, or actually four. You have the status quo and the change. And then you have the pros and cons for the status quo and the pros and cons for the change. Some of the people we work with are really convinced that this problem is a bad one and that they need to change. but they don't believe that the change will make them any better off. So if you don't believe that the change is going to be good for you, then you're not going to do it, even though you have lots of reasons to make change happen, or lots of reasons to be unhappy with the status quo. We also have the preparation stage where the challenge is then commitment and creating a change plan. And the change plan is really critical because the change plan has got to be accessible, effective, and acceptable. And we have lots of, in psychology, we have lots of good change plans that people won't do. Doctors have lots of good prescriptions that people won't do. So if you don't get the individual engaged and involved in the change plan, you won't get the change to happen. They just won't do it. And there are good and bad change plans. This is a cardiologist's office at the top of a steep flight of stairs. This seems to be bad planning. It may work for some triage process, but not treatment. So if I get you into action, you've got to start doing it. Now, we've thought about action. You know, people think about action as the going to the gym the day after New Year's. Okay? So on the 2nd of January, you're in action. But we think about the action phase. You don't build a pattern of behavior by going one day. Action really takes like 3 to 6 months of doing the behavior before we think of you moving into the next stage. So you've got to build a new pattern of behavior in order to do that. Now, why that's important is to know is that most of our treatment programs are less than 6 months. So most of we leave people in the midst of action for the most part, as opposed to doing anything more than that. Maintenance is the long haul. Maintenance is integrating a new behavior into a lifestyle. So if we want to get these heirs people to get employed, we need to get them to value their employment, to get involved in kind of being employed, to enjoy the benefits of kind of taking the paycheck home, and to kind of maintain that behavior over a long period of time. Now, I will tell you that the majority of these folks are unemployed, and actually HUD uses, though they were reported to HUD as kind of employed in some way, because HUD uses only 3 days of work during a year will count as employment. I'm hoping to get that at some point along the way, but to be fully employed. But it's not fully employed, but that's that's the minimum that they're trying to use as a marker for these folks who are really problematic and don't get employed. Now, the problem with this process is there's a lot of movement back and forth. So there's regression. Some people go into contemplation and decide not to do it. So then they go back to pre-contemplation. Some people go all the way up to decision making and kind of get into the plan and then realize they don't have the commitment. Now, that's not true of any of us, of course. I don't know about you guys, but I have a to-do list. And there's a lot of things on the to-do list that I've decided that I'm going to do. But there's a lot of them that haven't been done for quite a while and are still kind of on that list and probably aren't going to be done for quite a while. So the commitment is critical to kind of moving there. The other thing is that we slip. We don't continue doing the things that the new behavior. And we oftentimes relapse or go back to the old behavior. So the nice part about this model that we've done is that we've kind of conceptualized is that basically what happens to people as they slip or go back is they move into one of the earlier stages. So there's a recycling process that goes here. So the challenge then is to kind of understand this process as kind of people moving through here, but it's never linear, or hardly ever linear. That somebody just the first time kind of goes, oh, I think I need to do something, I've decided, I'm planning, I'm going to do it, and I've done it. Especially when you're trying to change a very chronic, problematic behavior. But you can see how this particular model meshes with kind of our unmotivated, unwilling, and unable perspective as well. And so you hope that people move like this through, And that, we get them the motivation, we help them make decisions, we give them the confidence in their ability, we use pressure and concerns to get them to go there, we help them with decisional balance and cognitive stuff. We know that they relapse, and oftentimes they come back in. So many of the individuals in this particular program have been through other treatments. They've been through drug treatment before. They need to come back through, they need to kind of try again to move through this process and get it right. And this process isn't magic. I mean, it's the process that people go through when they go to AA, or the process that people go through when they change any particular behavior. If you ask people who have tried a few times and then finally get it, they will report to you, I think I got it all right. I got all the pieces of the puzzle done well enough to support and sustain the change happening over time. And that's the real challenge. So what about this, now moving that challenge into multiple behaviors and multiple problems? Multiple problems complicate the process of change. So our challenge with these folks in the AIRS project is really to kind of help see where are the problems. Now all we've done is kind of listed 4 or 5 areas that we think you can look for other problems, and that's what the context is. But you can look at it from an individual perspective or an organizational perspective, that oftentimes there are problems at multiple levels. I ran an alcoholism treatment clinic in Houston, and everybody walking in the door had an alcohol problem. I mean, that's why they walked into the clinic. But that's not all they brought in. They had a lot of other things that they brought in with them. And so we had to deal with how do these other problems affect how they're going to change their drinking. So for the AIRS clients, how do these other problems that they have affect whether they're going to change, whether they're going to get employed, whether they're going to get off their substances of abuse, whether they're going to follow the doctor's prescriptions to keep the HIV from turning into AIDS. And it's also true, you can look at that from an organizational perspective. I'm not going to go there. The other understanding in terms of the model that we use is the problem is there are multiple problems. However, we think that the process is the same. So whether I'm asking you to deal with your drinking problem or your marital problem or your medication adherence, the process of what I have to do in terms of getting you to use these processes to move through these stages seems to be the same. So you can use a similar process with different problems. And that's hopefully simplifying for the case managers the challenges that they have dealing with the multiple problems. Now, we have to understand that the change goals and motivations are very behavior specific. And we need to get collaboration of the client. Whenever you have multiple problems, you have to decide what are you going to focus on. So what's the target and what's the context? The target behavior is what comes into the forefront and becomes, if you ever see the psychology experiments, you have the figure ground thing, you see the vase or you see the faces. Well, it's a figure ground experiment. Well, that's the same thing. When the people come in to the AIRS program, they tell you that they have HIV, that they need housing, that they're homeless, and so they're focused on that problem because they want in for that. But they also have substance abuse and lack of family support and other kinds of things that are going on. So you have to kind of decide how you're going to deal with those problems, which way you're going to go. And what we've done is we've created these multiple systems to try and deal with those problems. So we have lots of different care systems that are supposed to deal with the mental health problem and the substance abuse problem and the housing problem and the other kind of problem. The issue is that services are typically segregated by agencies, funding streams, targets, and objectives. However, individuals' needs and problems are integrated into their lives. And so what that means is that the individual then has to go to each of the organizations to try and kind of get each of those needs met. And each of those organizations has to figure out which problem is primary and which one they're most motivated to work on. And so, you know, our systems now kind of have significant problems, the mental health system and the substance abuse system, because if you have both of those problems, you walk in and the substance abuse group will say to you, you have a mental health problem. We need to send you over to the mental health clinic. And then you walk over to the mental health clinic and they will look at you and they'll say, well, look, you know, we can't do anything about your mental health problem until you stop using the substances. And so they send them over to the substance abuse group and say you need to change the substances before we'll deal with the mental health problem. So people have integrated problems. Services oftentimes are segregated, which is part of the issue even with the AIRS group. So we need to link needs and services to individuals, but that's not easy. So what are we trying to do? Well, we're building an evaluation program to try and help these folks figure out how serious the problem is, where the individual is in terms of the process of change, and then how can I figure out which of the interventions, where should I intervene, and how should I sequence this? Because these are case managers who look across the whole individual and try to deal with all of their problems. So they're trying to kind of find services and match services for the individual. And here's what we've done to try and do that. What we try to do is try to measure the key variables, like problem severity, motivation, priority, at both intake and each of the follow-ups so that we can actually track the progress the individual is making. The problem has been that what they wanted them is gainfully employed. But that's a long-term goal. You need to have shorter-term goals if you're going to try and help the case managers not to become totally distraught and give up. So we're trying to help them with multidimensionality, try and give them different measures. We want to try and make the assessment user-friendly. So it's got to be ease for use. We want to try and collect historical data once. This group had 2 or 3 big questionnaire packets that were being given to the patients at different times, many of them collecting the same data over and over again. We want to try and decide when we can get them to be most honest. If they're applying to get into the program, they're trying to sell themselves to the program. So we have to try and figure out when can we get them to really talk about their substance use. They don't talk about that. No, I have no problem with that, until they are accepted into the program. And then they say, oh yeah, well, I've been in substance use treatment for 5 or 10 times. So we have to try and help them to do that, decide when we can get the most complete. And then we have to facilitate the data transfer between people, which has become more complicated, I will tell you, with HIPAA. HIPAA is supposed to protect us, but it also gets in the way sometimes of communicating between healthcare providers. What we've done is we've actually had, as part of this project, regular meetings with the AIRS directors. We had focus groups with case managers. We've had the case managers review all the assessment instruments. We've done a professional review of the existing assessments. We reviewed the relevant assessments that are in the field currently. And we've met with different groups who gathered the data. Our last meeting was with the Empire Homes group that collects some data, and the AIRS case managers who collect some data, to try and see how we could facilitate the movement across those 2 systems to facilitate change in that way. We're trying to create an assessment system that evaluates patients as they move through the different parts of the system. So an eligibility, pre-entry evaluation, ongoing evaluations. They do have some housing meetings they have to go to. So we're trying to kind of see how can you build the assessment in so we can actually see how these individuals are changing over time and help these individuals do that. What we're also trying to do in this is to try and make the difference between the end goals, which they have lofty goals for these individuals. Living on their own, employed, living independently, and managing well. It's a good goal for all of us, actually, but that's their end goals. But to get them there, they've got to do the mediating goals, which have to do with job training and skills development and eliminating substance abuse and other problem behaviors and managing chronic conditions like with medication compliance. So we try to separate the end goals, the mediating goals, and then the process goals. Because where are they? Have you just worked to help them make a decision to do something about this? Well, that's progress. It's not progress that you can measure in terms of the product or the outcome, but it's progress in terms of this person now seems more engaged in the healthcare system. They've moved forward in terms of the process of change. They've increased awareness or acceptance of some of the problems. So what we're trying to do is identify, let me see, I think I may have jumped it quick. So we're trying to identify indicators that make a difference for the client. Now we're also trying to identify indicators that we made a difference in our project. If the case managers are better able to do their job after we give them these assessments and help them adopt these assessments, if the assessment system is used and found helpful, if the system adopts and embraces the new system, if patient progress seems more tangible to them, and if we see an increase in patients moving through the system more effectively, then we'll know that we made a difference in assessing these multiple problems. The ultimate goal of this project, I'm going to finish up here, is really still a work in progress. We've given heirs, as part of this, a revised assessment measures and procedures section that they are working with and they're reviewing. We're trying to strive to make some progress in how they transition from the Empire homes to the heirs, case managers, and doing that kind of stuff. And we realize that changing systems is as challenging as changing the multiple problems of these particular individuals. And finally, I just want to thank Roger Lipitz and the Lipitz Family Foundation for their support, to the heirs staff for helping us and letting us kind of collaborate with them and do this, to the individuals, some of whom are here in the room from the community collaboration that are here and who have done a lot of the work, and to the AIDS administration who really helped make this project ultimately possible by creating the Community Collaboration Center. Thank you. I have time for a couple of questions. I also, after the break and stuff, there's some information about heirs up in the front here if anybody wants to take a look at what they do and what their stuff is. Any thoughts, questions, comments? Yes?
I'm just wondering if your model of how people change includes or takes into account what might be called just totally irrational impulse behavior. In other words, your model looks like it's largely based on persuasion, kind of convincing people that this is what they should do.
Yes.
But my sense of this human nature is that you can be utterly persuaded, and the next thing you're doing the very thing you persuade yourself against. And so some other part of your brain just takes over and says, let's have some fun right now.
It's a good question. The question is whether, I mean, this is a pretty rational decision-making model, and whether there are other ways to change. And that some change actually that you see is really seems discontinuous. You're going along all of a sudden, and all of a sudden something happens and you do the opposite or you do something different. And that's a very good question. And I don't know if that's the same process or not. There's a colleague of mine who's been studying what he calls quantum change, where people kind of make leaps, like you have aha experiences and other kinds of things like that. Or I mean, prototypically, there's conversion experiences. All of a sudden, you're doing one thing, and then the next day, you go from Saul to Paul, and you're a different person. You fall off a horse, and you're now an advocate and writing letters and doing all that stuff. The question, it's not clear to me whether that's a different process. The reason I say that is because we talk about this and it seems pretty explicit. But in this process, there's a lot of what is called implicit cognitions. And they're doing a lot more work on implicit cognitions. So anytime you're thinking you're going in one direction, probably the seeds of another direction are there. But they're implicit. And you're evaluating. We look at that in terms of relapse. Some people have gone for a long time and they're sober for a year or two. And then all of a sudden, they start drinking again. You say, well, gosh, that seemed impulsive. It seemed like it was spur of the moment. But often, if you go back and ask them, there were some seeds of discontent with the sobriety. There were seeds of other things that were going on. And so I'm not sure whether the process is just more subtle or the process really is a different process of change. So that's the best way. Yeah.
Just off the cuff, which gender is more apt to embrace change?
Off the cuff. He wants me to get into. He wants me off the cuff to get into a gender dispute. Which gender is? We actually haven't found much difference in the process of change between genders. I mean, and when I say that, we've followed large numbers of people across 2 and 3 years, following them every 6 months, looking at them. Many of them were smokers or drinkers or whatever, trying to look at that. And when you look at the process across the two genders, it seems similar. Now, women will tend to endorse more of the processes of change. So they will tend to endorse a little bit more self-reevaluation in some of those. It's not clear whether they're engaged in those or they just endorse those a little bit.
The reason why I ask is I think in this society and most societies, women tend to be the caregivers, and there's got to be something that comes from.
Yeah, the caregiver. Well, I mean, caregiver is helping people. I'm not sure how it's involved in change. I mean, it oftentimes a caregiver can avoid personal change as much as go for personal change. So I don't know, but there is. I mean, we have not done any of the studies that are specific to that gender question, so I don't know.
I guess what I'm leading to is in the African American community, typically you have is a sort of female to male relationship, which is and typically young men who are addicted behaviors who are very much with their parents, in this case the mother,
Right.
to or the grandmother to get away with these kids. So I'm just wondering if there's any.
Yeah, I mean, family is really important in the change process. I mean, remember I said that there's lots of factors in the environment that are hindering or moving this process forward. And family is a critical piece of that. And clearly, it's not clear to me actually how they interact in the African American community at this point. And we looked at the numbers, and you see large numbers of folks kind of getting involved in the HIV and the AIDS. The challenge is to kind of understand how to promote change. And when you've got lots of multiple problems, which is I think part of this issue, all surrounding you, then there are protective factors. There's resiliency in that group at times, but there's also lots of people who are part of those statistics. So I don't know where that would fit into this. I mean, I think the churches are another, that's the other factor that you look at. And they tend to be a factor that tries to promote change, that tries to protect the community. Now, you need to know, one of our grad students actually did a study a while back on some of the churches and some of the substance abusers. Many of the substance abusers do not feel comfortable in the churches in there. They feel the stigma. So I don't know that the churches are necessarily a protective place or a place that actually offers support for change sometimes. And the same with family sometimes. Family is not a supportive place for change. It's sometimes a place that creates the havoc that the individual kind of then goes and uses drugs for. So it's not clear as far as I can tell. Other questions? Yes?
Do you know if any prison systems have looked at your model as a way to reduce recidivism?
That's a good question. Prison systems that have used the model. Yes, actually. They're using the model in a number. I just did a training with Gaudenzia. Gaudenzia does a lot of treatment of drug abusers coming out of prison. And they're trying to use the model and motivational stuff. Because this model is really a motivational model. It's really, how can you get people who are not motivated to move them forward? And it tries to help understand pieces of that puzzle. So that system's using it. There's a number of the prison systems in Illinois who are using the model. I mean, the model's a framework, so it's not a magic. It's just a framework to try and help understand the process of change. But yes, there are. Do you have a question?
I was just interested in your ideas about the intentional change and kind of the examined change versus the unexamined change, and how much emphasis you're putting on kind of the processes and the insight of understanding that within oneself.
That's a good question. I don't know that the intentional change model doesn't necessarily mean it's examined change. I mean, there is a decision-making piece of that, but we've used this model actually and look at initiation of substance abuse in teenagers, which looks totally kind of like it's discontinuous. I mean, they're just, one day they're not smoking and the next day they are smoking. But we've actually, with the data in Maryland, have been able to divide the elementary and middle school, I mean the middle and high school kids from survey data into pre-contemplators and contemplators and preparation folks. And you can see that it isn't always, I think, intentionally examined. That's what I meant about the implicit kind of knowledge and implicit attitudes that are there. So, you know, you have those things working all the time, so that what does look sometimes as discontinuous, you know, this kid walked up to you and said, "You want to try a cigarette?" And you say, "Oh yes, I'm going to do the cigarette." But there were a lot of things that were in the mix, probably not in the forefront. So I don't know that it means you have to be, it's not examined, but it is, the intentional means that you've got to participate in it if you're going to move forward and make it permanent. So that's more what I think of. And it's really interesting. I mean, I get examples from my own, you know, my own daughter. I mean, you know, when they were small, we'd be driving and they'd go, "Dad, guy in that car is smoking." I'm going, "Yeah, that's really, I mean, that's terrible. People do bad things, you know, it's, you can't stop them, you know." And then several years later, while she's in middle school, she's going, "Well, what the hell are you doing?" In my best psychological style. She goes, "I'm pretending to smoke a cigarette." I'm going, "Well, how did you get there from? I mean, it was terrible. I mean, how did you get there?" "It's not a real cigarette, Dad. Yeah, I'm not going to smoke. I mean, I'm just pretending." Well, so I don't know that it has to be examined. And then I think at some point, who may try a cigarette at some point? Well, then that's another piece of data. So what looks, I think, as relatively spontaneous and impulsive often has a lot of bubbling stuff underneath it that, you know, you go down to the mall and you see a professor that you like or a teacher you like from school who is smoking, and you go, "Well, it can't be that bad." That doesn't, you know, so you don't, but it just gets registered at a level that's not totally examined. And it's those influences, I think, that actually move us along and get us ready for change. So, for example, we know the cigarette tax that just came in January increased, doubled the calls to the quit line in the month of January. Okay? So that people kind of just say, "Oh, okay, well, they didn't move all through." No, there's people kind of going, "You know, someday I'll quit, someday I'll quit, someday I'll quit." And then they pay $7 for a pack of cigarettes and they go, "That day I think is coming quicker." And they decide quickly. And so the process doesn't have to take a long time. There can be, I think, lots of things happening relatively quickly, but there's always a bubbling of the process underneath that change. I mean, even the homeless, trying to get them off the streets. I mean, there's some discontent, but they think about things differently than we do. I mean, there's, you know, and they do think about it. I mean, we have a story of the homeless guy out in California that a colleague of mine told. That he kind of told her, he said, "You know, these people are trying to get me into a $500 apartment, and I'm living under a $2 million bridge." He said, "It doesn't make any sense." So from his perspective, he was doing the thinking. It was an intentional process, but his value system actually had a whole different cast to it. Other thoughts or questions? Yes?
Have you found levels of effectiveness with this model?
It's not a magic cure, that's for sure. What we have found is if you look at outcomes, if you look at the person where they are when they come in, oftentimes the outcomes, even in terms of the treatment outcomes, are related to where they were when they walked in the door. So initial motivation, and usually measured by these stages, actually predicted in a drinking program that we did, or project that we did, predicted their drinking even after 3 months of treatment for the whole year post-treatment. And it actually predicted where they are 3 years later in terms of the last 3 months of their drinking. So motivation is really a critical dimension. And what seems to be the problem in terms of effectiveness is actually how to really influence that motivation is not easy. And we don't really know how to do that well yet. So we're getting more. Motivational interviewing is one strategy that people are using. We're getting more strategies for trying to kind of learn how do you actually motivate people. I mean, it's clear that just telling them you've got a problem and you've got to change this doesn't work. I mean, relapse rates, I mean, people think relapse is really a problem of drug abuse. Relapse isn't a problem of drug abuse. The percentage of people who are diagnosed with diabetes who 1 year later are actually monitoring the glucose and doing the diet as they're supposed to is as great as the percentage of drug abusers who are abstinent 1 year later. It's about 20 or 30%. So it's not a problem just of drug abuse. It's a problem of kind of convincing people they've got to do the whole process, it seems to me, to get in there. And that's hard to kind of convince people to do.
I guess there would also be a lot of variation, and I'm wondering how you do that, how you change the model that you have to serve different patients or different people.
Well, yeah. It's a challenge because you've got to address the different problems as well as where the people are in the process. So we've created actually, we have a treatment manual actually based on the model that has two, because we believe that the early parts of the model need cognitive experiential processing and the later parts of the model need more behavioral processing. So we've actually created two sets of modules. So one set for people who are in the early part of the process in terms of this is for substance use treatment, and one set for people who are in the later part of the process. So it's a challenge. Yes?
I just wanted to know, have you looked into support groups as a motivational factor? I mean, by example, is that a strong motivational factor for?
Yes, actually. We looked at, particularly with AA, we've certainly looked at AA as a process. And actually, if you look at the principles of AA, they have a lot of the same principles that enable you to kind of go through this process of change. So if you go into AA, you don't need to be committed to change. You can take what's called a desire chip. So I think part of the wisdom of AA is that they really understood the process. I mean, we're not discovering a process. The process is out there. We're trying to kind of build a framework for understanding it. The AA process has been important for some people, but not all people can use that process to go through the change. But yes, we've done that. We've done that with self-change. We look at what people say that they've done, and what they say is remarkably similar to what are the elements of this process. So, thank you. It's been wonderful. A great group. I appreciate you coming out. Thank you.